Which of the following public health tools are used to do community assessment? A, mobilizing for action through planning and partnership, or better known as MAP, and the California Action Inventory. B, windshield survey and National Community Needs Assessment, the NCNA. The windshield survey and MAP, and I think there's a fourth one that I can't read. All of the above, is it? Okay. Enter your interesting. Okay, interesting. I'm going to go in and give you the answer because that's what we're going to be talking about. We're going to talk about the MAP and the windshield survey. I actually made up there's no such thing as the California Action Inventory. So that's a little secret of when you're writing test questions sometimes. But anyway, so we're going to get into this. For the next little bit, I'm going to talk about the whole idea of community engagement in regards to community assessment. So I'm going to talk about community assessment first. And I'm sorry, I'm going to go back. There's really two distinct ways to complete community assessment. And why in the world is this important? I could see you going, well, Joan, what's this got to do with, we're going to talk about community-based organizations, we're going to talk about community engagement. Well, the very first thing you got to do is really know the community that you're going to be dealing with, talking about, or trying to activate. And being a person that spent a lot of time in community health, writing community needs assessment is like the back of my hand, in that we did it all the time. But what became obvious over all those years of doing community assessments is the whole idea of how to do it in a systemic way, how to do it in an objective way. And so that's when in public health we have developed some very good tools to how to do that. And so the two distinct ways to do it is through primary, meaning actually directly collecting information from the people that you're working with. Secondary is to use some of the existing databases that are out there, or reports, I guess you could say. And not just literature at this point, but actual databases. So let's talk about the direct primary data sources. This may be something as simple as doing a survey. We actually did a survey way back when we were first kind of redoing and replanning for SCCAPE 3. One of the first things we did is our Ben, who was just here, helped us do a survey with all the what we considered potential audience people and all the people that had attended our conferences before. And we asked them all kinds of questions. Would you like to do it virtual? Do you want in person? What are some things that were good? What were some things not so good? So collecting that kind of primary data is absolutely important. I would assume most of you have heard about focus groups, and these are like, you can do them very professionally, you can do them less formally, where you bring the key people together of a certain group and you have directed discussion and you bring people together. Now, marketing people have got this down to a science, in that they bring people in and you talk about the product and they usually provide you with money. So that gets recruitment, gets people there. But in the social world and in the public health arena, focus groups are used a lot in order to get information directly from the people. You can also meet with key community representatives, including, let's not forget, elected officials. I'm showing here actually a meeting with elected officials, because they're the folks that have been out there, they know their areas, they really do, and they have a lot of information that they've already collected and may very well be able to provide for us. So this mobilizing for action through planning and partnerships, or better known as MAP. This is a very extensive tool that is in the literature, that it's readily available, that public health organizations have been using now for a good while. And being a person that was working in the health department, I used bits and pieces of this over a lot of years, okay? And it's a framework, it's a systemic way of looking at something, and it really helps increase your objectivity. It's your framework for your needs assessment. It helps you identify community themes and strengths of the community. The one good thing about the MAP is that they really emphasize the strengths of the community. We tend to want to go out, collect a bunch of data, and then we say, oh, look at the gaps. We've got high infant mortality, and we have high cancer rates, and we have, high incidence of sickle cell, and we have, all of these things, and we go from there. Where the MAP forces you to look at also the strengths as well as some of the gaps and problems. The local public health system is actually something that if you've been involved in the community out there and you've been at a hospital, say, you may not have been involved in the actual public health system, so you need to be aware of that. Those of us here in Virginia, we have a very comprehensive actual clinical care model that's in place. So we have clinics all over our state. And in North Carolina, they have clinics. But in other states like Nevada, there's not this whole network of clinics to serve the underserved. They have clinics there, but there's a different kind of network. So from what state you go to may be very different. So I encourage you to look at that, because it's amazing. Well, it's interesting to me. And when I got into public health, I had come from acute care and from Kaiser Permanente, which is a private entity, and I thought I was very knowledgeable about the community. I really did, because I had done a lot and I had good networks. And I get to the public health department and I'm like, oh my gosh, I knew nothing. I absolutely knew nothing. So learning that and looking outside of the world that you've been working in is really important. Also, looking at the community health status assessment is really important. Looking at what systems are there and looking at what the forces of change are, and looking what the assets are. We're very fortunate we have the Virginia Commonwealth University in this area, but some of you are in areas where you don't have that kind of asset. You don't have a major teaching hospital where there's a lot of good things that you can build from. So mobilizing for action through planning and partnership is a great way to do some of this. It's a tool, it's a method to tell the story. It's strength-based, which I really like, and you use your community members to collect your field data. So it has lots of input from your target. Let me just say for a minute, and when I'm using the word community, I am using that in a very global way, and I think as we talk, we need to be careful about that. I'm not necessarily saying the community as a geographical entity, but a lot of people are going to think of that way. And I know in our health department per se, when I say health departments, I think in a geographic network, because we had 132 health departments and 35 health districts, and I think that's how I think. But I'm using the term community in a more global way, in that we have a community of healthcare providers for the sickle cell population. We have a community of people with sickle cell disease. So please understand, I am coming at it from that background. So the 4 MAP assessments are the community themes and strategies, the local public health system, whatever it may be, the local community health system, which is going to include your hospital systems and your other. You may have federally qualified health centers in your area. You need to be aware of those. You may have free clinics, and most of our states have some kind of free clinic network. And tapping in, they all have some kind of organizational structure. I learned that very readily and very quickly in working in the health department, and so I learned to establish relationships with those folks and establish relationships with their key leadership. And then looking at the forces of change. You know, what in the world am I meaning about that? Well, that could be the political environment versus the type of economic pushes are going on in that community, who's driving that train. I mean, obviously, I live in Chesterfield County. It's the home of Philip Morris, okay? Well, that's kind of interesting if you're in the health field, but yet one of the major employers and drivers of the local economy is a company that makes cigarettes, which kills, what, 400,000 people a year in our country? I mean, you know, that gets interesting. But if you're doing a true community assessment, you've got to include those factors in what you're looking at. The map is actually sponsored or put on or supported by the National Association of County and City Health Officials, and it is readily available and can be used by anyone on from their website. This is a tool that is used. Oh, I want to go back. I want to show you quick. I don't know if you were paying attention to the little photo there. This is actually very realistic. I don't know if some of you have done some of this with bringing community people in, and you can have discussions and group work, and you identify, say, maybe the 4 major concerns in that area, and then you have the sticky notes, and people go up on the board, and you do priority setting. If you've done that, that's fantastic. If not, you may want to try it sometime, but this is something I've actually done many, many times in working with communities where we've done that with groups. And it's very insightful and a very effective tool to get groups of people that may not know each other. Another example of a map tool is this particular little diagram where all those little, what are they, hectagon or sexagon? And you may have groups of people that actually take one and go develop and look at, well, you know, assess what's going on in their community, and then you come back and you share that. So that's just a tool. And the other tool that I'd like to share, and when we were doing some of our initial SCCAPE, we actually asked our participants to actually do what's called the windshield survey. And I know I love this little picture, but it is what I'm showing here. It's a drive-by, not a shoot 'em up, but a drive-by. It's a public health tool that was developed actually by a nurse who was a public health leader. And over the years, I actually took her work and have adapted it several times and used it many times. And what it is, it's just a tool to address using observation, and it's actually you go out in a car and you drive around a neighborhood, or you drive around a city, or you drive around a specific geographic area. And in your virtual handbook, I have included the tool, the last one that we did that was adopted, and there's like an instruction sheet with the criteria, and then there's an actual form that you can use. You actually go out, and we suggest that you have at least 2 people, so somebody can drive and the other can observe, and y'all can talk, and somebody can take notes. And you look at all the different aspects of, let's say you're going to a neighborhood, or let's say here in Richmond City we're going over to North Side, which that has meaning for those of us that live here. But let's say north of the city there's neighborhoods, and we kind of talk about it being North Side. It's north of the river, and it's a fairly mixed population. And if you look at some of the other data, it's a variable on economic status and who's living there. But you actually would go over and drive around the neighborhoods, and you particularly, and in the grid that's used, you look at everything from what schools are there, where the police department is, where the fire department is, what kind of retail is there, what kind of recreational activities are there, are they parks, is there a gym, you know, what you physically physically go around and you check off and you look and you observe. You even look at things like, is there trash collection? Where's the health department? Well, what's the nearest hospital? So this form actually helps direct you to go out and actually observe. And then while you're out there, it also asks you to look at things like, well, are people out walking about? Is everybody in their houses? Nobody's out? And what actually is going on around? So it's actually a fun tool to use. I've used it in a variety of settings. And like if I was doing a training with community health workers, I would want them to spend an afternoon doing this. I would allocate time to say, okay, let's buddy everybody up. Y'all go out, do this tool. I want it to come back in, then we're going to sit down, we're going to look at it and share. I've done this with other kinds of students and where they've actually had to do presentations and talk about their community. And it's really interesting of what you find out. And even if you say lived in Northside, but you go out with your buddy and you drive around and you look, it's amazing how you might find out some things about your own community that you had never paid much attention to. So that's what this tool, it really is fun to do, but it's also useful. As part of this, I have to relay one story. I was doing some work down in Petersburg, Virginia, which is one of our poorer areas of our state. And we had our project going on, and we had our community health workers. They buddied up, and they had done the windshield survey, okay? And we had a very interesting conversation about that. So then one of the girls had this idea, and so this is what we did. We drove 3 of our community health workers out to the mall. Well, it was kind of I guess you'd call it. It was a mall. It had a mall to it. And we said, okay, you find your way from there back to the health department. That got interesting. And then another version of that is that I noticed that we were struggling with patients coming into clinic. And so what we did was they had to go from the health department, we drove them we did this one on paper, but we went out to their patients where they actually lived, and then they had to figure out how to get from that residence to the health department to clinic. And that's a very insightful thing to do. And that we find out that, some of our patients had to take 2 different buses. They had to do a transfer. Even though there was a bus stop right smack in front of the clinic, for them to get from their house to the clinic could take anywhere from 1 to 2 hours in 2 different buses. Think about a woman who's 9 months pregnant and you're going to make her do all of that, trying to get to the clinic for a prenatal visit. It was very insightful, needless to say. And these were people that had lived in the area and they thought they knew all about their community, but it was very insightful. All right, so now we're going to move into what we consider our secondary data sources. And this is things like census data, your national and state mortality data. Some of you are probably very familiar with the behavioral risk factor surveillance system. All of your hospitals that receive any federal Medicaid dollars must do a needs assessment on an annual basis and publish a report. Those reports should be available to you. I know in some places they're harder to get to than others because I've asked for them with the private hospital system here in town. Can I see your yearly hospital needs assessment? Oh, we don't have to provide that to you. Oh, yeah, you do. So you have to kind of go through the hoops, but it should be available. Other hospital data, like discharge data, admission, diagnostic data, etc. Now, nobody just off of the streets can come in and ask for that data because we have to be careful. But most of your researchers can get it. If you got to go through the right channels, you have to de-identify it and all those good things that happen, but that data should be available to your group as long as you've got the right mechanisms to do it. And then your state newborn screening data, which for us in the sickle cell world, very important. Now, I have to admit that in years past, that has been somewhat of a bone of contention. Some of you guys that are from some of the other states are much more advanced and have some of that data, where here in Virginia, we've struggled with getting some of that data. Now, I've been a person that was actually a supervisor over the newborn screening, and so, yeah, I had access to that data any day I wanted it. But could I just go and release it to Dr. Smith? Well, no, not with jumping through some hoops. So it just depends on what's going on, but it certainly helped. If I had been still there and wanted it, I'd have a little more ability to maybe make that available. All right, so some of the CDC data, and this is not my area of expertise, but on the data specific to sickle cell disease. This came up a little bit a couple days ago, and I hope everybody's realizing that we do not have a national sickle cell disease registry. Cancer we do, and some of these other diseases we do, but we do not in sickle cell. So in between 2010 and 2012, there were a couple of projects that came out of CDC, but they were very limited to what states participated. And so some of you are from some of these states, so you may very well have been very much a part of this. And if you have any major words of wisdom, I'd love to hear. But they collected data from people living with sickle cell disease from 2004 to 2008, and they developed some fact sheets. So if you go on a CDC website right now, you can find some of these fact sheets that actually were outcomes of these projects. The problem is these projects were based on limited funding, and so they're not forever, all right? In the public health research, epidemiology, and surveillance for hemoglobinopathies was only occurred in California, Georgia, and Mississippi. And they used a composite of newborn screening data, hospital discharge data regarding people with sickle cell disease. So they kind of put together what was available, and they also developed fact sheets, survey results, some guidelines on hydroxyurea, some peer-reviewed articles, of which I'm pretty sure many of you have seen those articles. All right. Since then, there have been, and this is where, all right. And here again, Dr. Smith and some of the rest of you are much more expert on this, in that in 2015, the CDC Foundation actually did another project to collect sickle cell data, and it was California and Georgia, which used their newborn screening and their other sources that they could get at to look at sickle cell data, all right? And out of that, and then there were recently in 2019, and Virginia is one of those states, a couple other states came on board, and those states at this point are not primary data collection data systems at this point, but they're really training states on how to go about doing this, okay? So we hope that there's some hope on the horizon. I'm excited that some of this is happening, and that at some point in our existence that there will be some kind of national database on sickle cell disease. Until we have that, guys, you know, unless you measure it and monitor it in the world of a politician or state health department, it doesn't exist. I hate to say that. So therefore, if we can figure out ways to actually collect the data, measure it, and look at it, we're going to have a better chance of getting some of those resources that we like to see that Dr. Smith was referring to the other day. Now, I understand St. Jude's Hospital also gathers data from multiple sources and puts together a report. So there are some secondary data systems out there that you could reach out to. And so, and I'm hoping that in years to come, that's going to be something that all of us are going to know all about, and we're all going to have our state data, and we'll have national data, and we'll be able to discuss this in a very different way. All right, now we're going to move on to this. I have to give credit to the American Society for Hematology, and then ASH Research Collaborative, which is a data hub that is really trying to collect all of this. And then in later, the Sickle Cell Disease Clinical Trials Network, which again, I know very little about, but I wanted to mention that these do exist and there are efforts going on to expand our ability to collect some data about sickle cell disease. There we go. Okay, now I'd like to spend some time talking about community engagement. And then we're going to feed into where Shirley's going to join me in a little bit. But hopefully I'm going to kind of lay some groundwork for community engagement, because this is something that some of you are experts on. Some of you have heard this and some of you are going, well, okay, what is this, Joan? Community engagement is working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues of affecting their well-being. I like this proverb. You can tell I like to pull out little sayings and proverbs, but go in search of people. Begin with what they know. Build on what they have. I like that. Yes, you cannot do community engagement until you know your community, know where they are, know what they already know, and what assets they bring to the table. Remember back we talked about Maslow's hierarchy of need? It's kind of like that. You kind of apply that concept to community engagement. You've really got to start at the way down here and then work up. All right. So some of what I'm going to talk about is, I'm up here with community engagement. Now, I'm very much into it. I spent a lot of time doing community engagement. Now, my topic at the time was infant mortality. I did a lot of work with that and worked with some very knowledgeable people that have written books on how to do community engagement. Community organizational change is absolutely challenging, all right? That was our definition. There's my proverb. See, I forget. Okay, community organization is the forming of bringing people together with special interests. For us, we've got that already. It's people that either have sickle cell, have family members with it, are advocates for it, or just have a particular keen interest in it, okay? Those folks come together, they want to do something about it, so they have to figure out, well, what is it they're going to do, what are they going to implement, how they're going to maintain that, and then how they're going to sustain it. All right, so those are very important. You must have what Ben was saying, this is so true. You've got to have a shared goal, and that's important to have clear-cut goals. If you've got 20 people and they all have a different goal, that's going to be really hard. And so trying to build consensus and get everybody engaged in a clear goal. And then there has to be some set up rules. Remember, he was saying, even in a social media support group, you've got to have some boundaries and some rules, and everybody has to be aware of what those rules are. Maintenance is actually engaging the members and keeping them engaged, all right? And that, here again. Sustainability, some of the work that I did, we actually had grant funding to help make that happen. Or the health department maybe threw us a few bucks so that we could hire people to facilitate meetings. And, and it's amazing how having a meeting out in the community, you got to feed people, and that takes money. So you got to find, well, where's that going to come from? I've been out way in the far southwest. If any of you know Virginia, we have a beautiful community out there called Abington. It's out there in that little point out there. It's beautiful country. But trying to reach out and get a community to come in and talk to us about some of these issues, health issues, that was a real challenge. And the biggest thing, we had to feed them, and we had to have a place where they could park easy and get in. And all these little logistical things you absolutely have to deal with. So your community engagement continuum is that outreach. That's what I'm talking about. You got to have ways to get to the people. Do you have a champion out there? Do you have a particular group? Maybe it's I know I worked at one point with a little church in I want to say Cumberland, Virginia, Powhatan, out in that neck of the woods. It happened to be a predominantly black church, but we were trying to get in and get folks in the Farmville area to come in to get breast cancer screening. And luckily there was a champion there, and she invited us in, and then we went out, and it really made a difference to establish some of that relationship. You have to do some consulting. You need to bring in experts who know about this. And you need to figure out how to involve people, and then how to collaborate, and then share the leadership. You cannot run a community-based organization that's going to get anywhere if most people, they're important, and they feel important, and you want them to feel empowered, but it can't just be Joni Quartermaid running the show, because most of the people are going to say, well, I don't agree with that woman, okay? So we have to figure out a way to share that leadership. Success is dependent upon each member must believe that help is needed, that there's something not right, that we need to. Now, I think in sickle cell, and Shirley's probably going to talk about this, we already know that. We have a big report that just came out that pretty much laid out a bunch of gaps, did it not? So that's great to have that kind of document in place already. But you may still need to get that input from the folks that you're working with. Must have some kind of common ground, must exist. There must be continuous negotiation, and each person must feel that there's some benefit. If they don't feel like they're getting anything out of it, that nothing's happening and whatever, I know from some years back when we had some issues with our community-based organization, and it was all one person doing a lot of things, and people stopped going and being involved because it's like, well, they don't listen to me, they don't want to do anything I want to do, so I'm not going back. Have you all seen that? Some of you have some very active groups, but I have certainly been in groups where you start with 50 people, and then it's down to 30, and then it's down to 20, and then you're lucky if you get a dozen people. And that's where you're not doing some of these other steps that you have to constantly do. Tips for engaging members. Now, I know this sounds absolutely, well, this is just common knowledge. But I was amazed at how some people didn't really think about this, and they expected, hey, I build it, they're going to come. No, it doesn't work that way. Everyone in our world is their own sickle cell disease expert. And they must embrace, though, that there's differences, and we must keep promises. We got to keep promises to ourselves, and we've got to go to the people. And I think we have to think about a spirit of fun, and meeting some emotional needs is part of the deal. I know our first SCCAPE conference when we had in person, that was probably, for me, some of the best parts of it, because I got to meet and interact with some people that I didn't really know, or I'd only known by name, and it just felt so good to be there and actually get to talk with people and interact with people and share a meal with people. Retention tips. Y'all all know this, I'm sure, but we've got to eliminate potential barriers. You got to plan for them, and you got to seek help, and you got to do what you need to do. One of the most common ones I hear is transportation. I don't want to come down to the VCU campus because then I got to park, and I got to do this, and I got to do that. See, we've got to figure out how to remove those barriers. We dealt with that a lot in some of the ones that I worked with. So some of those tips is use a buddy system, and I've used this very effectively, where you have a very active member and they reach out and bring in one of their buddies and act as a buddy, where make sure they know, oh, you remember tomorrow we have a coalition meeting at 1 o'clock at St. Peter's Church. Oh, that's right, I forgot about that. You need me to come by and pick you up? Oh, that'd be nice. Okay, so having a buddy. Make participation easy, whatever that is. Remove those barriers. Babysitting. We ran a group down in Norfolk at one time, and we had new moms that had not only transportation issues, but babysitting issues. So we had a little group, and we had volunteers come watch the babies while we had our meeting. And they loved it. And then we served refreshments, and everybody was happy, okay? Convenient times. You know, those of us that in academia used to be in, 9 to 5 kind of job, forget that. When you're doing community engagement, you got to be willing to go out on Saturday afternoon, Sunday afternoon, Saturday morning, 7 o'clock Wednesday night. We've got to go to them. And then we need to build that sense of spirit and welcome. And we only do that through being that way and talking about some of the things that we've talked about over this last 3-4 days. In today's world, we need to consider the use of technology, and of course with COVID, we had to use technology. So I think we're going to see a different world, as we've been kind of talking about and alluding to, and I think we need to build that in somehow. So I think pretty much the American people are getting used to Zoom, but can we make it more fun? Is there some other ways that we can make it more personable? And then I think the hybrid way of doing things is probably here to stay. I think I've even heard Dr. Smith say that somewhere in the last 4 days, in that it's in a lot of things that we're doing. We're going to have to start working with having virtual ways of dealing with this, but maybe adding in or adding back some of the face-to-face. So why do members leave groups? Well, it's kind of based on what we were just talking about. They don't feel included or respected. They go for meetings, nobody talks to them, or they try to say something, and they never get recognized, or they say something, which is the worst thing to do. Well, I really think that we need to da-da-da-da, and everybody just kind of rolls their eyes and looks at them and then goes on, So that's the kind of behavior, and I think Ben alluded to it in the social media. If you've got people that are disruptive, you've got to figure out ways to control that behavior. And it may be that they don't need to be there and you don't mind if they leave. But sometime I've always learned that I want to keep my enemies closer to me than my friends. And I have to relay a quick little story. Way back when there was a legislative study that my colleague and I, we were the lead that we had to do, and we had to bring together a group of people from all over the state, people we didn't necessarily know, and it all had to do with particular activity related to actually beta strep, and babies dying. And I said, well, the mother that created the study and the legislation and all that made our lives miserable that past winter, I said, well, let's reach out to her. I think we need to invite her to be on the task force. And my colleague went, are you kidding? She's going to drive us nuts, and blah, 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 blah. I said, I am not kidding. We want her at the table. We don't want to spend all this effort and time, and then we go do our little report, and she stands up. She's going to fight it, because she's not going to like anything we have to say. So we did. We brought Patrice to the table. She was wonderful. We brought all the key people. We had a wonderful task force, and we were very successful. And then the other sidelight of that is that after we did our report and we sent it in, there was a particular young person in the Attorney General's office, which I didn't know, and she did not like what we had to say or what we were doing. And she showed up at a meeting, and she was very negative, and she went back to her boss, and it got really ugly. I mean, ugly. But because we developed that nice, close relationship with our task force, man alive, they stepped up, man, and the letters and the phone calls were going into the AG's office and said, wait a minute, I was on that task force, and boy, that young lady got put in her place real fast. So we felt very good that we had done it right. Conflict with others, there's going to be conflict, so conflict resolution will become important. Unclear roles and responsibilities. Remember, Ben just talked about that, even on social media. Same principles here. You've got to have some rules, responsibilities, and guidelines. And don't, if people drop out because they're not seeing anything happening, they don't see changes, they don't see results, and so therefore they just drop out, don't care anymore. So how do we know it's working? Some of the general questions. Are members and clients, patients, whoever is in that group satisfied? So we got to find that out every now and then. Are programs meeting goals? Are things happening? Is the community aware of who we are and what we're doing? Because that may be an important part of it. So answering these questions will then help us. So in summary, and doing all of this wonderful stuff over the years and working, with many different kinds of coalitions and task force and some of these folks. The 4 key ingredients for success, I call my 4 R's: respect, and I'll say that, respect, respect. Relationships, we talked about a lot of that over the last 4 days, and I think it's kind of underlies just about everything we've talked about. Results and rewards, and that if we have showing respect, build relationships, are getting something done, and we all feel satisfied and rewarded, then you have a very successful coalition. So now I'm going to ask Shirley to come up and join us. And so she's going to get into, from her expertise and what she's been doing, directly with our sickle cell community-based organizations. All right? If you see that there's no questions at this time, but if you have some, please put them in the chat or even comments. And we will get back. I'll stay around and